All right, so today we're diving into something I think every ophthalmologist out there can relate to. We're talking about those sometimes sneaky, sometimes subtle ocular side effects from systemic medications.
Yeah, it really is amazing how many meds prescribed for totally unrelated things can end up impacting the eye. And as ophthalmologists, it's on us to connect those dots, right?
Absolutely. That's exactly what we're aiming for in this deep dive. We've got a ton of info here pulled straight from a really comprehensive medical text, and our goal is to help you guys out there recognize and manage these drug-induced ocular issues. Because ultimately, that's how we can provide the best possible care for our patients.
For sure, for sure. I mean, when you think about it as ophthalmologists, we're often the first to pick up on these side effects. We're kind of on the front lines.
Exactly. So let's get started, shall we? And why don't we begin right at the surface, literally with the eyelids? Turns out there are a bunch of systemic meds that can cause changes there.
Oh, yeah, absolutely. And some of them are pretty common too.
Totally. So first up, EGFR inhibitors. These are used a lot for treating solid tumors, and they come with a dose-dependent risk of a few things. The most common one you'll see is trichomegaly. Basically, that's just a fancy way of saying increased eyelash growth.
Yeah, for some patients, that might be more of a cosmetic issue than anything else.
Right, exactly. But then you've also got blepharitis and dry eye, which are definitely less fun. And then in rarer cases, you can even see cicatricial ectropion.
No, that's a whole other ball game for sure. Cicatricial ectropion usually means we need to get involved a bit more.
For sure. So another medication that pops up in our world is imatinib. It's used for chronic myeloid leukemia and certain gastrointestinal stromal tumors. And here's something really important to keep in mind, especially in your practice. A good chunk of patients, maybe even up to two-thirds, can develop some mild periorbital edema.
Yeah, I've definitely seen that. Usually it kicks in around 5 to 8 weeks after they start taking imatinib.
Yep, that's right. The good news is it's typically mild and doesn't usually mean they need to stop the medication.
Right, it usually goes away on its own.
Totally. But it's definitely something to be aware of and to reassure your patients about. Let them know it's not unusual and it's usually not a big deal. Oh, and I almost forgot, ptosis has also been reported with imatinib, although it's not as common.
Right, right. So moving on, there's dasatinib, which is used for acute lymphoblastic leukemia. It's been linked to a pretty rare side effect, eyelash pitylosis. Basically, the eyelashes turn white.
Wow, that's interesting. I haven't seen that one too often.
Me neither. But the good news is it's reversible. So if they stop taking the drug, the color usually comes back. Then there's ipilimumab for metastatic melanoma. This one can be a bit tricky because it can look a lot like thyroid eye disease.
Oh, really?
Uh,
That's something to keep in mind for
yeah.
sure.
Yeah, absolutely. It just highlights how important it is to get a really thorough medication history from every patient, especially when you're dealing with something like orbitopathy. You need to know what they're taking to make the right diagnosis. And the good news is the ocular issues linked to ipilimumab usually respond pretty well to systemic steroids.
Okay, good to know. And then there's bortezomib, a proteasome inhibitor used for multiple myeloma. This one seems to make people more prone to getting chalatzia.
Ah, yeah, those pesky chalatzia. I've had patients who just can't seem to get rid of them.
I know, right? So if you've got a patient with recurring chalatzia, it might be worth checking if they're on bortezomib.
Hmm.
And last but not least, for the eyelids at least, there's isotretinoin. This one can cause a whole bunch of issues. We're talking blepharoconjunctivitis, dryness, corneal opacities, even night blindness.
Yeah, isotretinoin can really mess with the ocular surface. It can even cause pseudotumor cerebri in some cases. But the good news is most of these effects are reversible once they stop taking the medication.
All right, so we've covered the eyelids. Let's move deeper into the eye itself.
Sounds good. Let's do it.
So starting with the cornea. One of the more visually striking corneal complications we might come across is vortex keratopathy, also known as cornea verticillata.
Right, and it has a pretty classic presentation too. It kind of progresses in stages.
Exactly. It starts with these fine golden brown lines in the lower corneal epithelium, and then they kind of branch out and start to look like cat whiskers.
Yeah, that's a good way to describe it, like little cat whiskers in the cornea.
Right. And then eventually they form this whorled pattern, usually just below the pupil, sparing the limbus. Sometimes you might even see pigmented clumps and some iron deposition.
Yeah, I've seen all of that. But even though it looks kind of dramatic, it's important to remember what medications can cause it.
Totally. So the big one here is amiodarone, the antiarrhythmic drug.
Oh yeah, amiodarone. Almost all patients on amiodarone end up with some degree of vortex keratopathy.
And it often shows up pretty quickly after they start the medication.
Right, and the severity kind of depends on the dose and how long they've been taking it.
Makes sense. But here's the good news for our patients. The vision changes are usually pretty minor.
Yeah, maybe some blurring or halos. And it's generally not a reason to stop the amiodarone.
Totally. And if they do stop taking it, the deposits usually go away over time, although it can be slow. We should also mention that amiodarone can cause other ocular issues too, which we'll talk about later.
Right, definitely. So next up are the antimalarials, chloroquine and hydroxychloroquine. And it's super important to remember this is different from the retinal toxicity we'll talk about later.
Oh, good point. So with the vortex keratopathy from antimalarials, it's a bit less predictable. There's not a clear link to the dose or duration of use.
Yeah, it's kind of a wild card.
Right. But it is usually reversible once they stop taking the medication. And sometimes it even clears up while they're still on it.
That is interesting. I guess those are the good cases.
Absolutely.
Yeah.
Okay, so apart from amiodarone and antimalarials, there are a few other drugs that can cause vortex keratopathy. And we should also keep Fabry disease in our differential.
Oh, good point. It's important to rule that out.
Totally. Okay, moving on to other types of corneal deposits. There's chlorpromazine, the sedative, which can cause these subtle yellowish-brown granular deposits. You usually find them in the endothelium, Descemet's membrane, and the deep stroma, especially in the palpebral fissure area.
Yeah, that's pretty typical for chlorpromazine, and it usually happens with long-term use.
Right. And again, we should note that this drug can also affect the lens and retina.
So, definitely something to be aware of.
Totally. Okay, now for a couple of interesting ones. Argyrosis, which comes from silver deposition, can cause grayish-brown granules in Descemet's membrane. And the conjunctiva can also be affected.
I've seen that one before. It can look pretty striking.
Right. Then you've got chrysiasis, which is linked to gold therapy. With long-term use of high doses, they can get these purple granules scattered throughout the cornea.
Interesting. And are those a problem?
Actually, they're usually not a big deal. They don't usually need to stop the gold therapy. And sometimes they even go away after the gold is stopped. But gold can also cause some minor lens deposits and sometimes a bit of marginal keratitis.
Well, that's good at least. It's always nice when the side effects aren't too serious.
Absolutely. Now, for another drug we need to watch out for, amantadine, used for Parkinson's disease, can cause white punctate opacities in the cornea. Usually shows up within a couple of weeks of starting the drug.
Okay, so if they stop the amantadine, those should go away too, right?
Yeah, exactly. The changes usually resolve with discontinuation. And then, last but not least, there's dupilumab for eczema. This one's been linked to conjunctivitis, herpetic keratitis, and even uveitis, which we'll talk about in a bit.
So lots to think about with dupilumab. We need to keep an eye out for all of that.
For sure. All right, let's shift gears now and talk about ciliary effusion.
Okay, sounds good. What are the key drugs here?
The one that comes up most often is topiramate. It's an anticonvulsant and also used for migraines. And it can trigger acute angle closure with secondary myopia due to ciliocoroidal effusion.
Oh, wow. So that's a pretty serious side effect.
Yeah, definitely. And you can see similar things with other sulfonamides like acetazolamide and also with bupropion.
Okay, so what should we be looking for?
Well, it usually happens within a month of starting the medication. They might complain of blurry vision, halos, eye pain, redness, that kind of thing. And when you examine them, you'll probably see a shallow anterior chamber and high intraocular pressure.
Okay, so we need to be on the lookout for that, especially in the first month or so.
Exactly. Early detection is key here. Treatment is usually aimed at lowering the IOP and stopping the offending drug. And if we catch it quickly, the prognosis is generally good.
That's good to hear. So what's next?
All right, moving on to the lens. And here, the usual suspect is corticosteroids, both systemic and topical. They're notorious for causing cataracts.
Yeah, those are definitely high on the list of cataract culprits.
Right. It usually starts with posterior subcapsular opacities, which can then progress to involve the anterior subcapsule too. And we also know that kids might be more susceptible to steroid-induced cataracts.
Something to be extra cautious about, for sure.
Absolutely. Now, the exact link between the dose, duration, and cataract development is a bit murky. But generally, higher doses and longer treatment mean a higher risk.
Right, that makes sense.
And while some of those early opacities might regress if they stop the steroids, they can still progress even after stopping.
Yeah, that's the tricky thing with cataracts. Once they start, they don't always just go away.
And of course, as ophthalmologists, we have to be super mindful of the link between topical steroids and both cataracts and glaucoma.
Right, always good to remind ourselves of that. Okay, so corticosteroids are the main culprit for lens changes. What else do we need to know?
Well, there are a few other drugs that can affect the lens. Chlorpromazine, which we talked about with the corneal deposits, can also cause these yellowish-brown granules on the anterior lens capsule.
Interesting. And do those go away?
Not usually. They tend to stick around even if they stop the medication.
Uh-huh. Okay. What else?
Then there's gold therapy, which can cause anterior capsular deposits after long-term treatment, usually more than 3 years. And allopurinol, for gout, can also increase the risk of cataracts, especially in older folks who've been on it for a long time or at high doses.
Got it. So more long-term effects to keep in mind.
Exactly. All right, let's move on to uveitis now.
Okay, sounds good. Uveitis is always a tricky one.
It is for sure. So one drug that can cause it is rifabutin, which is used for mycobacterial infections. It can trigger acute anterior uveitis, often with a hypopion.
Wow, so that can mimic some pretty serious stuff.
Exactly.
Yeah.
And there can be vitritis too, which sometimes gets mistaken for endophthalmitis. So that's something to be really careful about. And the risk is even higher if they're taking it with drugs that mess with its metabolism, like clarithromycin or fluconazole.
Okay, so that's important to know. What's the usual course of action if you suspect rifabutin-induced uveitis?
Usually you either reduce a dose or stop it altogether. And then there's cidofovir, which is given intravenously for CMV retinitis in patients with AIDS. With repeated infusions, it can cause anterior uveitis with lots of fibrin.
Okay, so another one to watch out for in those patients.
Yeah. And vitritis is also common with cidofovir, and you can even see a hypopion with long-term use. But the good news is it usually responds well to topical steroids and cycloplegics, so you don't always have to stop the cidofovir.
That's good to know. What else?
Okay, another interesting one, bisphosphonates for osteoporosis and other bone issues can cause both uveitis, usually anterior, and scleritis.
Oh, right. I've heard about that. And it can happen pretty quickly, right?
Yeah, usually kicks in within a couple of days of starting the medication, and even faster if it's given intravenously.
So that's something to keep in mind if you see a patient with new onset uveitis or scleritis shortly after starting a bisphosphonate.
Absolutely. Now, uveitis can also be linked to sulfonamides, although it's less common. And remember, these drugs can also cause ciliary effusion and angle closure, as we talked about before. Plus, they're a known cause of Stevens-Johnson syndrome.
Okay, lots of potential issues with sulfonamides. We definitely need to be careful with those.
For sure. And then there are the fluoroquinolones, especially moxifloxacin. They've been linked to acute pigment dispersion in the anterior segment.
Right, sometimes called BAI or BDI.
Exactly. We don't totally understand how it happens, but it might involve phototoxicity in certain people.
Interesting. And then there's the whole paradox with TNF inhibitors like etanercept, infliximab, and adalimumab. They're used to treat inflammation, but they can actually cause uveitis sometimes.
Yeah, it's kind of ironic. And there have even been reports of sarcoidosis in patients taking these medications.
So TNF inhibitors are kind of a double-edged sword. We have to be mindful of both their benefits and their risks.
Exactly. Okay, now let's dive into the retina. And this is where things can get really serious, because we're talking about potential vision loss.
Oh yeah, retinal toxicity is nothing to mess around with.
Right. So first up are chloroquine and hydroxychloroquine. They tend to build up in areas of the eye with lots of melanin, like the RPE and choroid. And while hydroxychloroquine is generally considered safer than chloroquine, it can still cause permanent vision loss if the dose is too high.
Yeah, and we're starting to realize that this toxicity might be more common than we initially thought.
Exactly. And it can even progress after they stop taking the medication.
Yeah.
So early detection is absolutely crucial here.
Totally agree. And that's where OCT comes in, right?
Absolutely. OCT is essential for picking up these early retinal changes, especially because they might not show up on a regular fundus exam at first.
Yeah, that's the scary part. Significant damage can happen before you see anything obvious in the back of the eye.
Right. So we also need to be aware of things that can increase the risk of toxicity, like kidney problems and taking tamoxifen. And of course, we have to make sure they're on the right dose. Obesity can lead to accidental overdosing if the dose isn't adjusted properly.
Oh, good point. It's all about that ideal body weight calculation.
Absolutely. Now, when it comes to chloroquine, the risk of retinal toxicity really shoots up if the cumulative dose goes above 300 grams. With hydroxychloroquine, the risk is much lower if they stick to the recommended daily dose, which is 5 milligrams per kilogram of ideal body weight. But even then, there's still a risk.
Yeah, it's not zero risk.
Right. Studies have shown that the risk of toxicity with hydroxychloroquine is about 7.5% after 5 years of use, and can go up to 50% after 20 years. And the risk also increases if the cumulative dose goes above 1,000 grams.
Wow, those are some sobering statistics.
They are, for sure. So what we really need to be doing is catching this toxicity in the earliest stage, which is called pre-maculopathy.
Right, before there are any visible changes in the macula.
Exactly. And high-resolution OCT is our best friend here. It can show subtle thinning of the outer retina, disruption of the iris junction, and loss of the cone outer segment tip line. Multifocal ERG can also be helpful in detecting these early functional changes.
Okay, so OCT and multifocal ERG are our go-to tools for early detection.
Absolutely. And it's worth mentioning that patients might also have some subtle visual field defects, which you can pick up on tests like the Humphrey 10-2 or Amsler grid. And they might have some mild color vision problems too.
So it's a combination of tests and careful history taking, right?
Exactly. Now, if it progresses to early maculopathy, you might start to see a slight drop in visual acuity and some subtle changes in the macula.
And what about OCT at this stage?
On OCT, you might see the flying saucer sign, where the central fovea is preserved, but there's loss of the outer retinal layers around it. And as it progresses further, you get the classic bullseye lesion.
Ah, yes, the bullseye. That's the one everyone remembers.
Right. That's where you see a central island of pigment surrounded by a ring of depigmented RPE and then another ring of hyperpigmentation. And in the later stages, you can get more widespread RPE atrophy, narrowed arterioles, and pigment clumps in the periphery.
Okay, so it can get pretty advanced. What are the key recommendations for screening patients on chloroquine or hydroxychloroquine?
So first and foremost, we need to educate our patients about the importance of regular eye exams. And then we do a baseline assessment with visual acuity testing and macular OCT, either before or soon after they start the medication.
Right, so we have a starting point.
Exactly. And then for routine annual reviews, we recommend starting those around 5 years after they begin treatment, unless there are any risk factors.
Okay, so lower risk patients start later.
Right. But for higher risk patients, like kids, those on chloroquine, or patients with other risk factors like age-related macular degeneration, kidney problems, or if they're taking tamoxifen, we should consider annual reviews after just 1 year.
Makes sense. Early detection is key, especially for those higher risk groups.
Totally agree. And of course, if we see anything suspicious, we need to talk to their rheumatologist about potentially stopping or changing the medication.
Absolutely. Teamwork is essential here. Okay, so what about other retinal issues we might come across?
Okay, so there's theoridazine, an antipsychotic, which can cause retinal toxicity if the dose is too high. It usually starts with this salt and pepper pigmentary disturbance in the mid-periphery and posterior pole, and then it can progress to more plaque-like pigmentation and eventually diffuse RPE and choriocapillaris loss.
Okay, so another one to watch out for, especially with higher doses.
Right. Now, chlorpromazine, another phenothiazine, is much less likely to cause retinal issues. It usually only happens with super high doses and long-term use.
Got it. And what about digitalis? I know that can cause some visual problems.
Yeah, digitalis toxicity can lead to all sorts of visual disturbances. Blurry vision, scotomas, photophobia, and dyschromatopsia, which is basically distorted color vision. And ERG can also show some abnormalities.
So lots of potential visual symptoms with digitalis.
Right. Okay, now let's talk about drug-induced crystalline maculopathies. And one that comes up a lot is tamoxifen for breast cancer.
Yeah, I've definitely seen that one before.
It's pretty uncommon at the standard doses, but higher doses can cause retinal toxicity and vision loss.
And what do you see on exam?
You might see these fine yellow crystals in the inner retina, along with some gray lesions in the outer retina and RPE. Maculopathy, including foveal cysts, is usually what causes the vision loss.
And OCT is good for picking that up, right?
Yeah, OCT is really sensitive for detecting those changes. And rarely, you might even see some optic neuritis, although that's usually reversible.
Okay, so lots to watch out for with tamoxifen.
For sure. Now, there's another drug called canthaxanthin, which is sometimes taken for tanning. High doses can cause these glistening yellow crystals in the inner retina.
Huh, interesting. I haven't come across that one before.
Yeah, it's not super common. And the good news is the deposits usually go away slowly if they stop taking it.
That's good to know.
Okay, another one, although it's not used much anymore, methoxyflurane. It's an anesthetic that can be metabolized to oxalic acid, which can then deposit in the RPE as calcium oxalate crystals.
Wow, so it's like little crystals forming in the back of the eye.
Exactly. And that can lead to some mild vision problems and even RPE hyperplasia later on.
Okay, so another one to file away in the back of our minds just in case.
Right. And then there's nitrofurantoin, the antibiotic, which can cause some slight visual impairment. and these glistening deposits in the retina.
Okay, so we've covered a lot of ground here. Any other drugs we need to be aware of?
A few more. Interferon alpha at high doses can cause a retinopathy with cotton wool spots and hemorrhages.
Okay, and does that go away?
Usually, yeah. It tends to resolve when they stop the interferon, and the visual prognosis is usually good.
That's good to hear.
Then there's desferrioxamine, which is used for iron overload. This one can cause rapid vision loss. You might not see much at first, maybe some mild macular graying, but within weeks, you can get these mottled pigment changes.
So that's one we need to catch early.
Absolutely. High doses of nicotinic acid can also cause a maculopathy that looks like CME, but it doesn't leak on fluorescein angiography.
Interesting. And what about pentosan polysulfate? I know that one's been linked to some retinal issues.
Yeah, pentosan polysulfate for interstitial cystitis can cause a progressive maculopathy, especially with long-term use.
And is there any treatment for that?
Unfortunately, no. Not yet, at least.
Okay, good to know.
And then there are alkyl nitrites, or poppers. They can cause a toxic maculopathy in younger people.
Wow, really? Poppers?
Yep. It can cause vision loss and photopsia.
Yeah.
And you might see a small yellow spot in the fovea.
Okay, another one to keep on the radar.
For sure. Okay, ready to move on to the optic nerve?
Yeah, let's do it.
So the big one here is ethambutol for tuberculosis. It's a known cause of optic neuritis, which can be acute or chronic. And the risk really depends on the dose and how long they've been taking it.
Right, that makes sense. Higher dose, longer duration, higher risk.
Exactly. It usually shows up a few months after starting treatment, maybe 3 to 6 months, but it can happen sooner. And if they have kidney problems, the risk is even higher.
Okay, so lots of factors to consider.
Yep. Now, they might not have any symptoms at first, but common ones are blurry vision, usually in both eyes, and sometimes color vision problems.
And what do you see on exam?
You might see anything from a mild to a severe decrease in visual acuity. The optic discs might be normal or a bit swollen, maybe with some splinter hemorrhages, and the pupils might be sluggish.
Okay, so not always a clear-cut presentation.
Right. And red-green color vision defects are common, but you might also see some subtle blue-yellow defects early on.
So we need to be thorough with our color vision testing.
Absolutely. Visual fields can also be affected centrally or peripherally. Now, if they stop the ethambutol, the prognosis is usually pretty good. But it can take a while for their vision to recover fully.
That's good to know.
And unfortunately, some people end up with permanent vision loss or optic atrophy.
So it's not something to take lightly.
Definitely not. So what we need to do is get a baseline visual acuity and color vision test before they start ethambutol. And we need to tell them to let us know right away if they notice any vision changes.
Right. Patient education is key here.
Absolutely. And then we should repeat those tests every 6 months. And if we suspect any toxicity, we stop the ethambutol immediately.
And what about isoniazid? It's also used for TB.
It is. But it's very rarely a problem on its own. The risk might be slightly higher if they're also taking ethambutol.
Okay, good to know.
Now, remember amiodarone.
Oh, right, amiodarone, the one that causes vortex keratopathy.
Exactly. Well, it can also cause optic neuropathy, probably because of demyelination.
Interesting. And how common is that?
It happens in about 1–2% of patients on long-term amiodarone. And it doesn't seem to be dose-related.
Okay, so that's something to keep in mind. But isn't it tough to tell that apart from eniodone?
It can be, yeah.
Yeah.
Especially since eniodone seems to be more common in people taking amiodarone. But it's important to try to differentiate them because it affects whether or not we stop the amiodarone.
Yeah, that's a crucial decision. So how do we tell them apart?
Well, a few things can help. Like, is the disc crowded? How fast did the vision loss come on? Is it one eye or both? How long has the disc swelling been going on? And are there any other signs of amiodarone toxicity?
Okay, so it's a combination of factors.
Right. Now, amiodarone-induced optic neuropathy usually causes gradual or sudden vision loss in one or both eyes, typically a few months after starting the medication.
Okay, so that's something to watch out for.
Yep. And about a third of patients don't have any symptoms at first. The most common finding is optic disc swelling, which can last for months, even after they stop the amiodarone.
So it can be pretty persistent.
Yeah. And visual field defects can vary a lot. Now, if they stop the medication, their vision usually improves. But about 20% of eyes get worse, and about 20% end up with pretty bad vision, less than 2200.
So not always a happy ending.
No, not always. Now, there's some debate about whether we should be routinely screening for this. There's no consensus yet.
Yeah, I've heard mixed opinions on that.
Right. But it's definitely important to warn our patients about the risk and tell them to let us know immediately if they have any vision changes.
Okay, good advice. What else is on our list?
All right, Vigibitrin, an anti-epileptic, can cause bilateral visual field constriction, mostly in the nasal fields.
Oh, right. I remember that one. And it's dose related, isn't it?
It is, yeah. It's not common at lower doses, but it becomes much more common at higher doses.
So something to be mindful of when prescribing it.
Definitely. And we should try to avoid using it in patients who already have visual field problems or who are taking other drugs that can affect the retina.
Makes sense. You don't want to add fuel to the fire.
Exactly. Now, for some reason, men seem to be at higher risk for the side effect, and it can take months or even years to show up.
Okay, so it's a slow burn.
Yeah, they might have some blurry vision or other symptoms related to their field loss, but they can also be totally asymptomatic, especially if the central vision is spared.
And what about the exam?
You might not see much at first, but you can get optic atrophy in some cases. And you might see some subtle signs like peripheral retinal atrophy, narrowed arterioles, and some weird macular reflexes.
Okay, so it's important to pay close attention to the details.
Absolutely. OCT can be really helpful here. It can show peripapillary RNFL thinning, even before the visual field defects show up on testing.
Oh, that's really useful.
It is, yeah. Now, the bad news is that these visual field changes usually don't go away even if they stop the vigabatrin.
Well, that's not good.
No, it's not ideal. But they might not get worse if they keep taking the same dose.
Okay, so that's something, at least.
It is. So the recommendation is to do a baseline visual field test and OCT before they start vigabatrin, and then repeat them every 3 months.
Got it. Regular monitoring is key.
Absolutely. Okay, now for a couple more optic nerve issues. Methotrexate, very rarely, can cause vision loss from optic neuropathy.
And that can be acute or gradual, right?
Yep, that's right. And it might be linked to problems with their folic acid metabolism. So it might be worth checking their folate levels and maybe giving them some B12 and folate supplements.
Okay, interesting. And then there's sildenafil.
Right. So we all know about the common side effects of sildenafil:
Hmm.
blue vision, trouble seeing red and green, and light sensitivity. But it can also very rarely cause NAIOnan.
Okay, so even those seemingly harmless side effects can be a sign of something more serious.
Exactly. We always have to be vigilant.
Agreed.
All right, one last area to cover: the visual cortex.
Okay, what do we need to know about the cortex?
Well, bevacizumab, which is used for certain cancers, has been reported to cause cortical blindness in very rare cases.
Oh, wow. That's serious.
It is, and unfortunately, it might not be fully reversible.
So that's definitely something we need to keep in the back of our minds, even if it's very rare.
Absolutely. Okay, so that was a lot of information, but I think it really highlights the importance of being aware of the potential ocular side effects of systemic medications.
Yeah, absolutely. As ophthalmologists, we need to be thinking about these connections, even when the drugs seem totally unrelated to the eye.
Exactly. A good medication history is crucial. We need to know what our patients are taking, and we need to stay up to date on the latest research.
And we need to work closely with our colleagues in other specialties.
Exactly. That's a great point. I'd